Hi and welcome. My name is Dr. Bill Gray and I'm here with Manesh Patel and John Runback. And we're going to be speaking regarding the pharmacologic treatment of PAD patients, a case-based discussion focusing largely around pharmacology, adjunctive means of kind of managing not just the intervention but also the larger patient. So Manesh, let's kick it off with you. I know you have a couple of prepared slides to kind of set us up in terms of how the data has been developed.
Yeah, thanks, Bill. And it's really a pleasure to be here with you, John and Bill. It's fun to be back talking about these things. And as we often do, when we think about the pharmacologic management of our patients, it's not just drug or device, it's everything. And I think today we're going to sort of try to put it all together. I'm just going to go through where the current treatment options are here, and I'm going to spend a moment or two making sure these are my relevant disclosures. I did work on some of the studies that you're going to hear about, actually a few of them today. So the first lesson I'll just say is to make sure before we talk about the new stuff is that your patients are on evidence-based therapies. This doesn't strike you like a big common conversation, but this is a paper we published now in 2012, but in 2016, Jeffrey Berger shown this too. This was in Denmark, so not in the United States. But if you look on this slide, people with PAD alone had a 50% chance of getting aspirin compared to people who had CAD. The same for statins, the same for ACE inhibitors. So we know our patients with limb disease don't often get the secondary prevention they should. And then that leads, not surprisingly, to graphs like this. Is the famous Mike Crickey paper in the New England Journal that showed if you're symptomatic with lower extremity PAD, your 10-year mortality is 75%. That's 1992, so now, over 20, 30 years ago, but it's not changed dramatically. So we don't often talk to our PAD patients and make sure they understand the symptomatic lower extremity disease at 10 years carries a significant morbidity and mortality. In fact, this is unfortunately the map of the United States. This is the amputation map. I live in North Carolina. I'm in the diabetes belt, the amputation belt, unfortunately. These are patients that don't get access to care and then lose limb, and that's obviously a critical feature. We showed this from Medicare when we did this in 2014 with Shriek Vimlapalli from our group. Up to 30% of patients did not get arterial testing prior to an amputation in the United States. So we're going to talk about pharmacology, but the first thing is to recognize the disease and get them on evidence-based therapies. This might be the first big pharmacologic trial for vascular disease. This is called the Capri Trial. Many of you will remember this. This was aspirin compared to clopidogrel in all comers, people with vascular disease, coronary disease. And now, over 30 years ago, this showed that clopidogrel was better than aspirin, but not by a dramatic amount. Just look at those, absolute risk reduction there, 5.83 versus 5.32. So a 0.5% for MI, stroke, or vascular death. This is before ACEs were really widely used in beta blockers, but it told us how good clopidogrel was compared to aspirin monotherapy. It did lead to clopidogrel being used some more, but it was expensive at that time and was not used instead of aspirin. So in general, I'd say, in people with vascular disease, clopidogrel is indicated for PAD patients. It's mildly better than aspirin, as I've just shown you. What about 2 versus 1? This is the Charisma trial. Aspirin plus placebo versus aspirin and clopidogrel. Again, broadly in patients that had coronary disease, actually had some diabetic patients without coronary disease, vascular patients. Again, about a 0.5% relative or absolute risk reduction. This didn't meet statistical significance. It was a pretty large trial, even several thousand patients. Deepak Bhatt's one of his original papers in the New England Journal. So I would have concluded from there 2 is not dramatically better than 1, maybe a little bit better, but not much better, and statistically no different. And then I participated for a long time in the Euclid Trial, what we thought was going to be a landmark platelet trial, because we were under the impression that more antiplatelets would make people with PAD do better. It's important to remember in this 14,000 patient trial, a very small number of these patients had critical limb ischemia. 5%, it was still 500-600 patients, but the majority were claudicants. Many had had a prior revasc. Ambulatory, that an ABI less than 0.8. Many of them were probably in the 0.68 to 0.72 range. And about half of them had prior lower extremity revascularization. We followed them for 26 months, and unfortunately, we were surprised to find that ticagrelor was no different than clopidogrel in the elder PAD patients who had not just undergone a revascularization. So, at least from this part of the talk, I would say, we know that vascular disease is at risk for our patients. We should do evidence-based therapies, but more antiplatelet therapy might be a little bit better. It's not dramatically better than let's say, aspirin or clopidogrel itself. That leads us to some of the data on rivaroxaban, and we're going to spend some time today talking about why I think about this. I haven't yet shown you the Compass trial. The Compass trial is not on your slides, but it's an important trial where they, again, like Euclid, took chronic CAD, PAD patients, actually more CAD, everybody had CAD, and then some of them had PAD. That trial, if you would have asked me before it started with 2.5 milligrams of rivaroxaban on top of aspirin compared to aspirin, if you would have said to me, Manesh, is that going to be positive? I thought it was going to be a stretch, to be frank. Because that's a broad population. How do you make people that have vascular disease live longer when almost everyone could get in? The high-risk patients in the overall trial was actually stopped early for a mortality benefit for the 2.5 milligrams of rivaroxaban plus aspirin. I was surprised by that finding. That finding then led us to think about the Voyager trial, where we said, let's take 6,500 patients with lower extremity PAD undergoing an acute peripheral revascularization. And it's worth recognizing roughly 30 to 40% of these patients had a surgical revascularization. The other 60% had an endovascular revascularization. If they had a hybrid procedure with say, a cut down and an endarterectomy of the common femoral and then a stent of the SFA, they were actually counted in the endovascular group. So it's endovascular plus sort of hybrid, because that's a little bit different. So anybody who got a stent sort of is in the endovascular group or got the balloon angioplasty. These patients got rivaroxaban 2.5 milligrams twice daily plus aspirin versus placebo plus aspirin. So it was just Riva on top of aspirin therapy. And some would say, well, what about clopidogrel? I'll talk about that in a second. But the key was we allowed clopidogrel in either arm if the investigator wanted to use it. So you can imagine that even though it wasn't randomized, the right-hand group on this slide was aspirin, placebo tablet, and clopidogrel when the doctors wanted to use it. Mostly endovascular doctors, the surgeons weren't using it as much. On the left side, it was rivaroxaban, aspirin, clopidogrel when people wanted to use it, again, mostly endovascular doctors. When was the drug started? It was started after the procedure. So it was allowed any time from the day of the endovascular procedure to 7 days after the surgery, whenever the investigator felt the patient was stable. And you can imagine that means that likely we were picking people who hadn't had a big hematoma and weren't having a bleed, because people wouldn't want to randomize into that. So it is a little bit selective in that regard. The other innovation in this trial, if you ask me, is the primary efficacy endpoint. It wasn't just CV death, MI, and ischemic stroke. The FDA did allow us to put acute limb ischemia and major vascular amputation. And I think that those are key limb events that did go into the primary endpoint of the trial. And then the major bleeding, TIMI major bleeding, was the primary finding of the trial. So this is the primary endpoint of the Voyager PAD study out to about 3 years. The first message I would say is when we do an endovascular or surgical revascularization on our patients with PAD, 1 in 5 at 3 years is going to have acute limb ischemia, major amputation of vascular cause, MI, ischemic death, or CV death. That's a pretty big finding, right? I didn't think about it at the time, but I didn't think 1 in 5 of my patients was going to have one of those events. So it's something to think about. We know they're sick and they're elderly, but it's worth noting. And then the rivaroxaban arm was statistically reduced with regards to that endpoint with an absolute risk reduction now of 2.6%. So put that into context of what I told you about those antiplatelet therapies. So the absolute risk reduction at 3 years was a total of 2.6, or a hazard ratio of 0.85. And this finding, I would say, started pretty quickly with 6 months. Absolute risk reduction is about 1.5, with the number needed to treat about 65. 1 year gets to be about 2%. And out at 3 years, it's still sort of separating at 2.6%, with the number needed to treat 39. Now, of course, we don't do anything to all of our patients, so we try to figure out who are the riskiest patients that might benefit the most. So we'll talk about that some. But I did think this was a meaningful finding for our field, where roughly for the last 20 years, it's been aspirin or aspirin and clopidogrel. Well, there's no free lunch. Every time you show a reduction in stroke or limb events, you got to say, what's the bleeding? And certainly here, I would say this is important, that the ISTH major bleeding wasn't the primary endpoint, but was statistically increased at 1.5% absolute risk increase. TIMI major bleeding was not statistically different, but almost a percentage more of that. Still pretty low rates of bleeding. You know, endovascular patients, we've gotten pretty good at getting in and out of the femoral artery. Now we're doing pedal, we're doing different areas. So we certainly have patients that we can get in and out of without much bleeding. Obviously, I told you the trial enrolled patients after they were stable, so they'd have to be stable. This is the primary endpoint with and without clopidogrel. Sort of the question everybody asks. Now, I want to make sure everyone understands these are not randomized patients. They were just whether or not the doctors decided to give them clopidogrel or not. And what you can see is those patients without clopidogrel had a higher overall event rate. Those were likely surgical patients predominantly who have a higher rate, because doing a big surgery on a patient tends to be a patient who's got even worse disease than some of the endovascular or claudicant, potentially non-CLI patients. Nevertheless, you can see from this finding that the hazard ratio is pretty similar between both groups, 0.85 and 0.86, and there wasn't a p-value for an interaction with clopidogrel. This was now published in Circulation. The lead author is the late Will Hyatt, who obviously led this group and we think a lot about with the vascular space, and so I want to make sure we give credit to some of the work he did in leading the trial. And then sort of to put it together, I sort of say to people, how do I think about the trial? Because again, you got to put things in context. If I think about acute limb ischemia, major amputation, MI, ischemic stroke, and CV death, you can see that for every patient that we treat with rivaroxaban 2.5 twice daily after an endo or surgical procedure, overall it's 181 less events out of 10,000. You know, another way to think about that is about 18 patients out of 1,000. So, you know, depending on how many you're taking care of on any given year, acute limb ischemia, major amputation is pretty large. The safety outcome is 29 more, with no difference in intracranial hemorrhage or fatal bleeding, but mostly bleeding that's skin-related or other. So that's the risk-benefit from the Voyager trial, which I think is something we're going to make a decision on as we go through our cases to say, how do we make those choices? Another way to think about how I think about vascular disease now is that early on, after a revascularization, just like a coronary revascularization, the limb or the heart artery or that vessel is at risk. And Voyager sort of speaks to that. You know, rivaroxaban was studied with some efficacy in Atlas, but most people would still say DAPT in the coronary post-stent era. Late, when you're thinking about chronic disease, Euclid probably fits in that category and shows me that more antiplatelet, at least with ticagrelor compared to clopidogrel, is no different. I wish it was a 3-arm study. We talked a lot about it. We would have loved to study it against aspirin, but just didn't have the funding and support. You can think about Compass there in that space where Riva now chronically might have a benefit. So it's something to think about as I think about across that broad group. This is something Skylar Jones from our institution I put into practice. And, you know, one of the schematic here is to think about how we think about the antiplatelet therapies we've been using for so many years. As a cardiologist, I grew up in a field where stopping platelet aggregation was critical whenever I blew up a stent, whether it's in the coronaries, whether it's in the periphery, in the carotid, in the legs. And to be honest, we know from many years that stopping that antiplatelet aggregation helped our patients. We have IV versions, we have PO versions. What we've recently started to learn is that if we can get the right dose of a 10A, there's 11As coming, you know, these drugs that inhibit thrombin through a sort of mechanism which it can also play a role at the platelets, you might get 2 ways to prevent that escape and potentially reduce brain, heart, and limb events. So I do think we're getting to an era where we're going to have more tailored therapy for our patients, which will be beyond just the antiplatelet work. So, you know, I'll just end by saying a lot of drugs get approved, but how you use them in our patients is really where the magic of being the art of medicine is. So this is part of why I think this will be a fun session, because I've spent about 15 minutes going through the data, and now we can look at some cases. So don't forget to manage all the risk factors, and then we'll talk about which therapies to use for our patients. Thanks, Bill.
Terrific. No, that was a great overview. John, do you have any questions? I wanted to try to bring out a couple of things, but go ahead.
Yeah, I mean, there are a couple of notable things there. You know, first of all, compared to Mike Kricke's article, you know, we're seeing now a more contemporary series of reduction of almost half the magnitude of cardiovascular event rates. Still very high at 20%, but, you know, considerably better than the 40% seen at 3 to 5 years now.
Yeah, it's a little aged for sure.
Yeah, so.
But 20% is not small, but it's a significant improvement.
Oh, absolutely. And what strikes me about this is, we're very actively involved in the Voyager trial, and strongly believe in the concept of giving, some sort of DOAC in this population. But from Compass, we already learned that if you give this, in patients who are at risk of acute events or progressive limb events, you can reduce the magnitude of those events up front. So, it would be nice to look at a population of patients who are pre-treated, with rivaroxaban for some period of time, perhaps as a roll-in, and then, of course, treated afterwards to see what the magnitude of effect is.
This is a great question you ask, right? So this is sort of the yin and the yang of trial design and thoughts, right? We said, when should you start the therapy? You'd ideally like to start the therapy before the intervention if it's going to stop intraprocedural thrombosis.
Right.
And, not knowing enough about the variety of peripheral procedures and the bleeding events and risks during procedures, it was hard to plan that. But you're right. Ideally, we would like to see that. And some people have said now that we have Compass and Voyager Manesh, what do you do through the procedure space? Right. It's not known, but in general, we're asking people to keep it up all the way to the day of and maybe not get that morning dose and go through the procedure.
Right.
Has there been a look at any grouping between the endovascular and surgical outcomes?
Yeah.
I know it wasn't pre-specified.
No, we did talk about it.
Clearly, there's a question that could be answered there.
Yeah, no, it's a great question. And so to get to your point, there are two we stratified randomization, both by clopidogrel use, even though it wasn't randomized, and by whether you plan to do endovascular or surgical. I didn't show you the overall trial, but there's no p-value for interaction amongst any of the subgroups, including surgical or endovascular. Okay. But it does look like the surgical patients get a bigger benefit. The hazard ratio is 0.82 or so instead of 0.85. The endovascular patients get a little bit less benefit, 0.90. But that may just be the math of the way that it works. But the event rates are also lower in the endovascular patients, so it's sometimes harder to show a difference. Nevertheless, there was no significant interaction, and the endo patients also got the clopidogrel, and there was no significant interaction. So I think both of those are important questions.
And so for the audience too, was there a dominant event in the composite that drove any of these findings?
Fundamental question that I didn't show all the slides for, but this is something we learned in Euclid too. When we did not show a difference with ticagrelor versus clopidogrel, right. It's something to be sitting in a steering committee after 4 years, unblind a big trial and go, how did we miss this so much, right? And now sitting back years after doing Voyager, what I think we don't pay enough attention to is that our PAD patients that are predominantly PAD patients, even if they have a heart history, but they're presenting consistent with lower limb event, they're probably a different phenotype than the 50-year-old smoker who's coming in with a lot of MI types. Even though I know it's the same atherosclerotic process, but the bed and what's happening is different. So when we look across those two trials, the PAD patients tend to be older, tend to use more tobacco, and tend to have more diabetes. Won't surprise anyone who takes care of PAD patients. So what we now know, looking across that sort of disease spectrum, is that in Voyager and in Euclid, but certainly in Voyager, the limb events after an endovascular are sort of dominating things. So if you look at the total number of events, about half of them are the limb events. So in the first year,
and that drives the differences between the groups.
Drives the differences. I mean, there's no difference. So again,
I know it's a composite. So
I guess the way I think about it is, the biggest event happening is the limb event, and the efficacy is best seen in the limb event.
Right.
However, when you go down all of those and look at ischemic stroke, the point estimate still looks like there's a benefit, but it's not as you go through each statistical one. CV death, the point estimate is right at 1 or a little bit of 1. People have said to me, Manesh, what does that mean? And I'll just say CV death in an older patient in these trials, it's hard to know what the cause of death is. I know we're calling it CV death. So same thing like Euclid, where we saw that in the cause of death in an older PAD patient who's found at home or doesn't have a limb-associated death may not be modifiable. It's hard to modify causes of death when people start having cancer and a variety of other things.
One of the things, the reason I ask, and I know that this analysis has been done, but this is an enriched population for atrial fibrillation.
Yeah.
You're giving them low dose, albeit low dose, nevertheless, but we know that DOACs work to reduce events in AFib.
Is that how stroke gets?
And I wonder if the stroke is modified by that. And I think I've talked to some people in the Voyager program that told me that there really was no difference in terms of AFib occurrences.
Not as much, right? So the two places we've asked this really great question is the Compass trial, which was 24,000 people or so. I wasn't involved in that study, but I was taken aback, as I said, that trial was positive, and then when you looked, MI was sort of positive, stroke was really positive.
And that's actually the thing that got me on it.
CV death was really positive. So, in that Compass older population, and I've gone back to the McMaster investigators and said, are you sure no one had AFib?
Exactly
Did you have any monitors? And they said no. A lot of those patients were enriched for carotid disease, which is artery-to-artery embolism, which you could argue we hadn't studied well enough with DOACs. And so I think the data for me, at least in Voyager, is driven by limb events when we're working on the limb. And a lot of times what I've now said based on the polyvascular disease is whichever bed you're working in or whichever bed has caused the event before, that's the highest risk bed. So when you take a CAD patient, they're more likely to have an MI. You take a PAD patient, they're more likely to have a limb event. Cerebrovascular patient, they're more likely to have a stroke.
Right. I think there's also a population that we increasingly see have chronic kidney disease. So they already have platelet dysfunction. You can see why the antiplatelets may not confer as much benefit as you might like, whereas we know that anticoagulation can be beneficial, but in the past, the risk-reward was not favorable.
In Capri, you could understand it because there may be a 25-30% non-responder rate.
Right.
But ticagrelor kind of takes that out of the picture. So
yeah, not only that, and
doesn't
in
really
fact, in
get you there.
ticagrelor and Euclid, the FDA at the time made us do CYP2C19 testing in the entire trial. So as hard as it was, we excluded any homozygous people with CYP2C19 problems. So Euclid is a pure, it's a, as I said at the start, it's a mono fight. It's one
Right.
strong
But
against.
they would have been presumably randomized in a large trial, would have.
Yeah,
would not have
so
been
why
a-
we
yeah.
were so against pulling them out is we were like, in the end, we screened 16,000 people,
That's exactly
randomized
right.
14,000, and of them, we think there were like 400 CYP2C19.
Exactly. It wouldn't have made a difference. Yeah.
If you're big enough, it won't make the
Right.
difference. Yeah.
Okay, well, let's move on. Thanks for that. It was a great discussion. And let's move on to our case-based presentation.
Yeah, thank you. That's remarkable. I've obviously been exposed to that data a number of times, but to hear you present it again, is really enlightening. So
Sure.
I can't thank you enough. And it's, it's really robust data set. I think it warrants review several times.
It does,
Really
and
understand it.
we're unfortunately haven't had as much chance to look at it. So, when we look at the data, we keep learning more and more as we go through it.
And I'm going to go back and watch, this, session as a
As
an
a-
audience.
that's right,
member
yeah.
As well. So, my task here was to talk about a patient with peripheral arterial disease as an endovascular therapist is the population that we're treating. So obviously, it's against the background of coronary artery disease and renal vascular disease and diabetes and so forth and so on. But this particular patient was rather typical of what we see. 78-year-old woman, about 6 to 8 weeks of ischemic rest pain in the right foot, routinely waking up from sleep each and every night, which is only relieved by dangling her leg or getting up and stomping her feet on the ground. She had some prior right femoral revascularization with stent placement 6 months previously. She'd actually, prior to us, just 1 week early, had failed endovascular procedure at another institution, and then was referred to us to give it another shot. So she had numerous cardiovascular risk factors typical of this population: an active 50-plus year smoking history, 1 pack per day. Currently, hypertension, dyslipidemia, non-insulin-dependent diabetes mellitus, although her hemoglobin A1C was reasonably well controlled. I think it was 5.6 or 5.7. She had aortic stenosis, which was planned for TAVR somewhere in the near future. And she had medically treated coronary artery disease, and I don't know the details of that, other than that she had a history of some chest pain and had actually at some point undergone catheterization, decided to treat this medically. No cerebral vascular disease, no history of TIA or stroke. Renal function was good in this particular patient, although at least 1 in 4 of our patients have chronic kidney disease. And she had no symptoms in the contralateral limb. You can see her medication, so not too bad. I think I agree with you that unfortunately in our population in the tri-state area, New York, New Jersey, Connecticut, half of patients come in remarkably not on guideline-based medication, which I always find astounding. Or if they are, they're on like atorvastatin 10, which is not sufficient, since we know they need moderate to high dose statins at the very least. So she was on Levoxyl, atorvastatin 40, aspirin 81, verapamil, enalapril, metformin, and clopidogrel. So dual antiplatelet therapy, medication obviously for her blood pressure with the ACE inhibitor and a calcium channel blocker, and the oral hypoglycemic in addition to the statin. On examination, very, very weak Doppler DP and PT signals in the affected extremity, which is cool. Refill was present, but very sluggish, probably more than 5 seconds. She obviously had chronic disease. She had, trophic changes. She had brittle nail beds and so forth and so on. So all the typical changes you see, and some relative atrophy in that limb compared to the other limb as well. So this had been an acute process superimposed on something more chronic. And just to sort of, show off, I guess, for a moment, the type of things that we and other people who specialize in endovascular therapy are really routinely able to do now. This is just a couple of pre and post slides. She has multi-level disease. It's funny, you made a comment coming in here that you think of coronary artery disease as 3-vessel disease. I guess I could think the same in peripheral arterial disease, right? So she had femoral disease, she had popliteal disease, she had tibial disease. So she's already polyvascular, even though it's just one limb.
She has a profunda stenosis as well, was probably why she was so symptomatic, right?
Exactly right. So her SFA was out, the previous stent was out. We don't see anything until we get downstream into the calf, where we can sort of faintly, make out AT reconstitution. And we're able to go ahead through a number of, really very cool techniques that we all utilize now to restore uninterrupted straight line flow down through the pedal arch. And now we're faced with this dilemma of what to do. She was already on dual antiplatelet therapy, and despite that, it had progressive disease. She's she's got multiple high-risk features. I was asking you earlier what those are in REACH, for example, or CART. We could talk about that. But she has polyvascular disease. In addition to the polyvascular disease in just the extremities, she has a history of coronary artery disease that we know of at least. Diabetic, although reasonably well controlled, dyslipidemia, the critical AS, and now critical limb ischemia, which is 2/3 of the population that we're treating at this point in our practice. So, tough question. What do we do? So, in the past, really up until we had participated, in Voyager, we would probably just put this patient back on antiplatelet therapy, or perhaps have considered what's done in Europe quite a bit as a month of, anticoagulation with, Lovenox, if we can. She's not a dialysis patient, so that's certainly possible. And we know that anticoagulation can benefit these patients in the short run and reduce thrombotic events, but with the trade-off of, higher bleeding risk, particularly higher fatal and intracranial bleeding risk. So we would have sort of been stymied and hoping for the best, that prior therapy, which had not succeeded in reducing her event rate, limb events in the past, would now be somewhat better, that we'd restored flow. But obviously now we had the data from Compass and the data from Voyager. I didn't know if we could liberally discuss the Voyager data, so I just alluded to Compass here. But we know these high-risk patients do better with rivaroxaban and aspirin than with certainly single antiplatelet alone. And again, clopidogrel is equivalent, I think, but slightly higher bleeding risk. So, if you look at the difference in that magnitude of vascular events in REACH and CART, again with those high-risk features of diabetes, renal insufficiency, coronary artery disease. You can see here it's 8 to 5.8 and 7.5 to 5.6, and lower thrombotic acute limb ischemia rates, which are really notable in this patient. So that's what we did. It's now actually been about 3 months with her. She continues to do well. We, see her in follow-up. She's got very good arterial, imaging. Everything's remained patent, and she's got signals. And that's the crux of it. One thing I want to comment on what you said a little bit earlier, which struck me as a little enigmatic, is that I personally believe that these endovascular patients actually represent the highest risk cohort, because they represent patients who often have anatomic features and or clinical comorbidities which prevents them from being surgical candidates. So we're treating often the sickest and the worst, and therefore the highest risk patients, where there might be greatest magnitude of benefit.
I think that's right. I think it's probably, I'll show that when I show my case, you might see much simpler claudicant type of a case, but the reason I'm doing that is I think the spectrum of what people see is variable on two axes, endovascular versus surgical. I'll call it very simply critical limb ischemia versus claudication. And so if I take your practice, which is, as you said, 2/3 or 70% critical limb ischemia, then you're right. If you're doing that endovascularly, that's a very high-risk population. I didn't go into, it's been presented at least in Voyager, the critical limb ischemia group had a substantial benefit. Now they're probably significantly surgical and endovascular, but critical limb ischemia is a marker that probably overrides a variety of other things. And
they're an event-rich population.
Yeah, right. It's a very.
It's true. So, yeah.
That's right. So it's a dependent on where you are and what you're doing. But I think the country is still doing more claudicant, younger endovascular.
But to your point, I'd love to see that sub-analysis, surgical versus endovascular patients, both in terms of what their features and clinical characteristics were, as well as the magnitude and effect of differential therapies.
Yeah, I'll have to definitely both be good. And they've been done and presented. And I think you're right, that's part of what we do. And even more, what are the procedures? Because here you do a very nice job on, one of the things I've often said about our space is a multi-level patient seems like they're much higher, their risk is much higher, but presenting and proving that their multi-level disease is higher. Or is tibial, where the vessel's 3.0 and it looks like a coronary.
Right.
And is that
with a low high resistance outflow?
High resistance, yeah, right. So is that a place where so that's unknown in our space, I think.
So let me ask you a question. You can guide me, with your insight here. I think you mentioned earlier that the general practice is to limit certainly antiplatelet therapy, dual antiplatelet therapy, post-procedure. I'm presuming now, and our utilization, this is lifelong therapy, right?
Well, I would have said, even before we did this, even though I think I've highlighted that in general practice, I think unfortunately, whether it's this therapy, dual antiplatelet therapy, statin therapy, unfortunately people just don't take things long, and we don't prescribe them long because they don't want them. But the data would be that to really protect your patient here, she's 78, and the average lifespan in the United States still another 10 years potentially for her, maybe less with the critical limb ischemia. I would be using it for several years in her, for sure.
I mean, we advise our patients that we're maintaining these medications forever, not just for limb, but life for us. The only thing we may ever back off on silostazole, perhaps.
Yeah, you'll see I've stopped that for sure because people have done that.
So, I mean, you referenced this, I think, appropriately as a high-risk patient. She comes with acute limb / critical limb. She's failed once. She's got polyvascular risk factors, and she's a polyvasc to begin with. And you put her on Riva BID based on the Voyager data. But the Voyager data was developed in all risk categories of peripheral intervention.
Right.
So the question I have for you, somebody who clearly believes in the therapy, what percentage of all your interventions are you putting them on? And what do you think the penetration in the community is, and where should it be?
Yeah, that's a great question. So, obviously, I fancy myself a vascular medicine doc, so I pay close attention to this data. But, this is, largely an interventional radiology meeting, right? So I think it's important, my being up here, perhaps the greatest value is to get out to the interventional radiology community treating PAD to understand.
That's the genesis of my question, really.
The pharmacology that's behind all this, so we can provide, optimal, background therapy. Because, we can't rely on other people to do it. That's for certain. It's incumbent upon our procedural success that we provide the appropriate medications afterwards, and the data is compelling. So pretty much we've done this on all patients. I mean, occasionally, unfortunately, run into insurance issues, with the rivaroxaban, but if not, this has now become our go-to therapy.
Good. Do you have any pushback from the primary physicians or anybody who's referring in? They want to know what the hell you're doing with rivaroxaban and their patient?
I can't speak for all practices, but they really, look, we're driving the statin therapy, we're driving the antihypertensive therapy, we're driving, so this is just one more thing that we're telling them is necessary. So.
All right,
that's fantastic, and it's a testament to sort of your what I'll say is very high quality practice to be thinking broadly across all these things.
Right.
Right?
Well,
These
as I
are
keep
not
saying,
whether you're interventional radiology, cardiology, or surgery, it's still not done. I showed you rates of less than 50% use years ago, but even more recently for statins. So.
And one day we're all going to be patients. So it's incumbent upon us to do the best thing.
That's
thing we can now. So
get the place there.
Right. So let's go to our next.
Maybe I'll go to the
case,
second case, and it's sort of I figured you might do a critical limb or at least a high-risk patient. So I tried to get somewhere in between, but maybe we can decide about that. So same disclosures as before. 76-year-old woman who actually was seen in 2 other clinical spaces in the North Carolina area. Actually, worked out in an area where she was on a farm and did some work there and had a history of tobacco, hypertension, had a PCI to her LAD, and in the past had a left SFA intervention, was on aspirin and atorvastatin. Somebody had tried silostazole, which she hadn't filled, or tried for a little while, didn't feel well about. And when she saw us in clinic, she'd had pretty bad buttock leg claudication and had an ABI on the left side of 0.62, no palpable femoral pulse. And so we took her to the cath lab thinking we could have done more imaging, but thought, she's got an iliac lesion, it's either occluded or not. We would try to get across it and see how we did. She's actually had some back surgery too, so there is a prosthesis. Actually, her SFA and below the knee, single level, almost pristine. Sometimes you see the smokers where you'd say, there's been disease, I'm not sure what exactly that intervened in the subsequent, but it looked pretty good. And so thought, well, we would go up and over and try to cross the lesion. Got access from below, so we'd have bilateral imaging.
I used to have an old vascular surgeon partner who'd say that when he saw those pristine infrapopliteal vessels, he'd say, well, that's because there's no inflow of blood pressure.
Yes, right. It's like
it's probably
the plaque has gotten down
probably
there.
True, actually.
That's probably right. So you could see a sheath going in, a wire getting passed. We get a wire across and eventually spend some time putting in this isn't a covered stent, this is an open cell. We'll talk about whether it's drug-coated or not in a second. Pretty good result.
Great result.
Pretty straightforward. Most would say she's going to feel great. But I was sort of left here at the end of this case thinking the common scenario. Almost no one in our practice, I can tell you, even before any of the data I showed you today, would have just left her on aspirin. Almost everybody ubiquitously likely would have said aspirin plus something. Most of the time that was going to be clopidogrel.
For how long?
And that's great. Our fellows used to, and still do this. They go, how did you come up with that number, Manesh? And I'd say, well, sort of handshaking, right? So if it was a drug-coated product, there's some package inserts we talked about. But usually it was somewhere between a month to 3 months was the practice, unless you had a coronary reason, and then it was extended. I was saying that in Medicare, we'd looked at this data that on average, people are about between 30 and 60 days on clopidogrel. and then the Compass or Voyager data, and then clopidogrel monotherapy. So we have also in our group started doing this, and I can tell you across our, like, say, 8 to 10 different interventionalists across the health system, there's a differential uptake, right? There's some people who are still hesitant to go to Riva. A lot of, probably 80% have gone to Riva plus aspirin. The difference isn't in starting Riva plus aspirin, it's whether or not you continue the clopidogrel or not. It's an interesting concept because there's a concern about early stent endothelialization, and in the trial it was used, and so I don't have a concern if people want to start it. Actually, I find it in the smaller vessels, and again, purely in my own mind, not based on data, in the smaller vessels that are more coronary-like, if there's a lot of disruption or things, then I might actually add the clopidogrel on top of that.
We do this in coronary stent PCI all the time. If somebody in AFib gets a coronary stent, we make a decision, an assessment of their bleeding risk. And if they're a high bleeding risk patient, we modify the antiplatelet therapy, and we do something different with the DOAC or not. And so I think that why shouldn't we start talking about this population in those terms? I think that's a very reasonable thing to do.
I actually think it's a great analogy. And in fact, your analogy, what happens in the coronary side is we drive our stroke risk when we think about AFib.
Right.
So after we put the stent in, we're still thinking about AFib, and we go, okay, I want to make sure I treat the AFib, but I'm going to do something to make sure the limb is okay or the heart's okay. I would say the same here. We should be being driven by what that limb's going to look like in 6 months. So you might be adding Riva and aspirin, but then how long whether you add clopidogrel or not is going to be based on a decision in my mind on what you had.
Also the vascular territory. I mean, you're dealing with a 7 or 8, 9 millimeter vessel here with great flow and a relatively short stent segment with a good outflow into the hypogastric, and distal vessels are great. If you're dealing with a 3-vessel infrapopliteal critical limb patient where you got kind of a metsa result, then I think the conversation is a little bit different. And again, the bleeding risk tolerance goes up.
That's right.
And you go to a different place.
I think it's a great point. So I think
bring up a great thing about this risk assessment, because I'm sitting here and asking myself, have I sort of asked patients, or have I thought differently on a patient who, say, had a CVA in the last 6 months that I'm not going to add rivaroxaban? And it's not really been, a deciding factor for us, because of the low rate of intracranial and fatal bleeding. It's not in any way been a differential factor for us at this dose.
Especially at this low dose. I think the bigger issue for me is if I'm adding clopidogrel or not when I'm deciding that, because now I'm going to a triple therapy even though at a low rate, and so that's how I think about the problem. I think about it saying, is there something in the patient's history that's making me try to add that back? It's not a lot, but occasionally that.
Right. Yeah.
So I think that's the end of my case, and I'll stop there for that and see if there are other thoughts.
Two great cases. I think they illustrated, patients of different risk presentations. I think your patient seemed to be a little bit more vascularly challenged.
Yeah, sure.
For lack of a better word.
I like that.
But I think they both qualified according to Voyager in terms of, you would include both those patients in the trial. You'd have given them rivaroxaban as a placebo or oral placebo, and they would have done well, and they would have had a low bleeding risk going forward. We know it works out to 3 years. The lines continue to look like they're at least parallel, if not separating, and so the presumption is that lifelong therapy, I think we can take that away from the Voyager trial, the lifelong therapy, unless otherwise contraindicated, is appropriate given what we know about the time to event curves.
Yeah, I think that's right. And I guess the one thing we have here, this is something I sometimes say because I've been involved in development of some of the different compounds. People sometimes say, Manesh, how do we get to the 2.5 milligram dose? So first I tell them, remember it's not apixaban because there is a 2.5 milligram apixaban dose, and that's an AFib dose, although not used much in AFib. It shouldn't be used much, but 20 milligrams is the AFib dose, so you have to be very careful about that confusion. The second is the 2.5 milligram dose of rivaroxaban from Atlas and the ACS territory, and then Compass before Voyager. It's probably the most studied randomized dose, surprisingly. Even though we use those others, it just came to us in the United States late because we haven't had Compass and Voyager as indications until recently for Compass. And then Compass gives me comfort in the sense that they randomized people 5 years out of an MI that had coronary disease and PAD, and chronically followed them. So if I have a Voyager patient who gets revascularization for 3 years, and then I have Compass data 5 years out of an MI, I feel like I have a...
You've handed it off to the next trial.
I've got a large sort of overlap where I could say, I think at this dose, if you can tolerate on it, you're going to do okay for a few years.
I have one question based upon our cases. One notable feature of both of our patients was the smoking. and obviously yours was smoking-related disease almost exclusively. In my case, she had a lot of risk factors. But, how about the data for rivaroxaban in current or recent, smokers? I mean, because that's a population that represents a particularly high risk for acute events. I mean, many people surgeons certainly won't operate on patients who are active smokers.
No, that's right. It's hopefully an older version of what we used to do in practice, but true. I think, as I don't remember the numbers exactly, but I know both for Compass and Voyager, again, that risk factor did not change the treatment effect. None did. So that, usually you think if you look at 20 things, one of them just by statistical chance is going to be out. So we were encouraged to see that, again, it seems to be, if anything, a little bit more effective in smokers, as you might imagine, because they have a higher thrombotic risk. And the other thing that I think at the American College of Cardiology coming up is going to be interesting is the total event analysis, not just the first event, recurrent events. So how many times, not even after you had your ALI, because we all know that once you've been to the lab for a thrombotic event, it starts a pretty bad domino to get knocked down. So that analysis, I think that Rupert Bowersox is presenting as a late breaker will be interesting because I think it shows a totality of effect over many years, so it's not that, many of these analyses are timed to that first event.
Yeah, some of these long-term analyses as well as some of these subgroup analyses are going to be really compelling.
I think so. Getting the data out is going to make people more comfortable.
There are data which go back decades that demonstrate that Coumadin therapy in patients with atherosclerotic disease works.
Might be beneficial, yeah. If you can get the bleeding right.
But we can never get the bleeding rate right. So I think this is a kind of a ratification of that concept. And it's interesting that the antiplatelets didn't really stack up well enough it wasn't powerful enough to do that. So what's next for Riva? Like, what's the next frontier? Is there another population at risk that we need to be considering here in terms of, or is it just analyzing data we have, which is voluminous?
I think that's probably the case. I mean, I think, I was, lucky enough to be part of the AFib analysis study that was first done with Riva, but also at that time, nothing had beat warfarin. So I think we live today in 2021 and after a pandemic, a lot of things have changed, but in 2010, 2009, when these trials first came out, I used to say warfarin was Muhammad Ali was 50-0. It never lost a trial, right? Even we didn't like it. It was rat poison. Nobody likes to use it, but it had not lost.
The devil you knew.
That's right. But it was the devil you knew. And so these therapies have been actually really a revelation across many of these therapies across the world and have certainly improved human health. In the vascular disease space, I think that just as we described, the transition from acute coronary disease to chronic coronary disease, acute vascular disease to chronic vascular disease, that's still an area where these analyses and these trials will be important. And then, we've just seen what's happened with MI. Now we've seen what's happened with the limb. I see that revolution happening with PE, where we now go and do endovascular things for PE. Obviously, it's going on for stroke. So if you think about where the next set of therapeutics, whether it's factor 10 or 11 or others coming, secondary stroke prevention, acute PE to chronic PE management, those pharmacotherapies are going to be worked out as we get more, just like everything else, we get better with the device and the technology going into it.
Are there any plans to look at AV dialysis grafts? I mean, this is such a ripe, look, DCBs have made a huge impact. Really changed the face of the patient experience there and their families who have to deal with all of that. Oh, it's awful. And so now they've been extended, and that's real. But thrombosis is such a big component. I know it's hyperplasia and restenosis leading to thrombosis, but there must be something there that might work.
Fantastic question. In fact, when we were doing Voyager early on, we had a thought about thinking about AV fistulas or also thinking about ultrasound sub-study to see what percentage of restenosis could you affect. Because we knew that our investigators and clinicians would want to know, boy, if you could stop thrombosis and at a certain level of hyperplasia, manage it. Never got around to getting it done because of the operational tackle. But I do think your idea is fantastic. And if not these agents or agents that have a little bit better renal clearance are ripe for it, right? And so I do think at this low dose from Voyager, actually, the renal dysfunction population is another subgroup that's going to come out that I've seen some of the data for. Again, similar to the overall trial. But I think specifically for dialysis access, which is just a cycle of life, as you know, is a critical one. I think it's a great idea. And I think the last frontiers are renal dysfunction, dialysis, valves, mechanical and bioprosthetic.
Which is still problematic.
Still unknown, right? And cerebrovascular, those secondary stroke.
Especially intracranial disease.
Intracranial disease, secondary stroke, where today if you come in with a stroke, if it's not AFib related, you still go home with platelet therapy and then.
Sure. Just one last voice for me. I admire your optimism in saying, now that we're after the pandemic.
Yeah, I should say after.
The pandemic's still here, and it's interesting. But obviously, patients who have COVID or have recently had COVID have higher thrombotic events. We've seen a lot of these, patients coming out of the woodwork who we've had to treat for peripheral arterial thrombotic events or superimposed acute on chronic ischemia. This potentially represents a novel therapy for that population as well, where ALI is sort of a unique presentation.
I think it's a great point, and I am aware that I know that at least one of the NIH active programs is looking at full dose versus at least some regular standard prophylactic dose, and then, as you know, there's a few studies ongoing with the medically treated dose of rivaroxaban, but other anticoagulants too, and I think there is some NOAC data at ACC, but these patients are at high risk. The drivers of that thrombosis is clearly of panvasculitis.
Yes.
So the biology, I think, is very similar to the ways
It'll be interesting. Well, listen, terrific overview, great cases, great discussion. I want to thank John Runback, Manesh Patel, and thank everybody for watching and listening. Enjoy the rest of your week.